The following two lectures will be examining the herpes viridae family of viruses, that is what we refer to as the herpes viruses. We'll talk about human herpes virus 1 and 2 in addition to varicella zoster virus in the first lecture. But first, let us start with the general properties of the herpes viridae. The herpes viridae are a big family of viruses. There's more than 100 members in this family, about 120. These are large viruses, they are enveloped, and their genome is double-stranded DNA. This big family of viruses can infect a big number of animals, different types of animals, and they can also infect human beings. However, only 8 have been shown to cause disease in humans so far. These viruses can go into a latency program. So these are viruses that can cause latency. They can first infect the patient or human being, and they might cause primary manifestations, that is, clinical disease that then subsides. But during that period, what happens is the virus uh, goes into hiding in one of our tissues or in an organ, possibly. And then later on in life, what could happen is that you have reactivation, the virus is produced again, it gets shed again, and you have um, manifestations later on in life. Now, I usually like to distinguish between latent viruses like the herpes viruses and what we call persistent viruses. So, latent viruses such as the herpes viridae, they can go into complete silence, into complete dormancy. You do not produce complete infective viral particles during latency, but you might make, or the virus might produce some of its proteins, and these proteins are required just to sort of maintain things, to suppress the uh, viral complete replication. Um, I would like usually to distinguish that from persistent viruses, whereby these viruses, the persistent ones, they are continuously produced. They do not completely go into a silent mode. You have virus production going on, even if it's a little bit of the virus. So I usually like to distinguish that from the latent viruses. Now, with the herpes viridae, we have several causes of reactivation that are possible, but we do not completely understand these. These might include, or some studies have shown that some of these factors include stress, and stress by itself might lead to the production of cortisol, which might suppress the immune system or depress it a little bit. Age as well, the older you are, the more at risk you are of reactivation. There are environmental triggers like exposure to sun, which would include UV exposure or ultraviolet light exposure, cold, wind, so on and so forth. Um, Immunosuppression, of course, is a big factor that we believe does induce a reactivation. Menstruation is also a stressful condition by itself. Other types of infections and trauma or injury, all of these might cause reactivation of the virus. To date, we know that there are about 120 species that infect animals and humans, and like I said earlier, there are only 8 that cause infections in human beings. There are 3 subfamilies. The alpha herpes viridae includes 4 genera. Of importance to us amongst these genera is the simplex virus genus, which includes HSV-1 and 2, which we'll discuss in the first session, and then varicella-virus, the varicella-virus genus, which includes VZV. The beta herpes viridae, we also have 4 genera of importance to us are the cytomegalovirus genus, which includes CMV, which causes human disease, and the roseolovirus genus, which includes HHV6 and 7. And then the third subfamily is the gamma herpes viridae, also includes 4 genera of importance to us, are the lymphocryptovirus genus, which includes the Epstein-Barr virus, and then the retinovirus genus, which includes HHV. The following table summarizes the various properties of the herpes viruses, things that you learn about in the 2 sessions today. Um, so you'll notice that these viruses have a formal name and a common name. So the formal name is the taxonomic one given to these viruses by the ICTV, compared to the common name that um, you often read in various sources, and you'll hear people referring to these viruses by their common names. So, for example, human herpes virus 1 or HHV1, this is the formal name given by ICTV to this species, and the common name is herpes simplex virus type 1 or herpes simplex virus 1. Or another example is human herpes virus 4, HHV4, and usually we refer to it as the Epstein-Barr virus. Now you'll notice that the alpha herpes virinae, they go into latency and nervous tissues as compared to the other two subfamilies um, that affect other types of cells or tissues. So for example, the CMV, it can infect or can go into latency and different types of cells, and that includes lymphocytes. Similarly, for the others, lymphocytes are a place where these viruses can reside, go into latency, and then reactivate later in life. The disease manifestations are summarized here for you to be able to study them, but we will talk at length about these manifestations in our upcoming slides. Let's start with HSV-1 and HSV-2. On the following slide, we have a couple of tables that summarize HSV-1 and HSV-2 manifestations. Here's how you decode these tables. If you have a minus sign, this indicates that the manifestation is rare with the indicated virus. If you have the plus or minus sign, it means it's more common with the other type of HSV infection. So the minus sign doesn't mean that this kind of manifestation doesn't happen at all with the indicated virus. It's just rare. And the plus or minus means that it likely happens more commonly with the other type of virus indicated on the slide. Now, all of these eight human herpes viruses, we believe that they do not uh, uh, exist in animal reservoirs, so they are exclusively found in human beings. The HSV-1 and HSV-2, as members of the alpha herpes virinae subfamily, their site of latency is nervous tissues. So um, for HSV-1, latency happens in the trigeminal ganglia, and then for HSV-2, latency happens in the sacral ganglia. HSV-1 is more associated with young children compared to HSV-2, which is more seen in young adults, and that's mostly has to do with how transmission happens. Transmission of HSV-2 is mostly sexual compared to HSV-1, whereby transmission happens via contact, usually via saliva. Now, some manifestations are more seen with the primary infection and rather exclusive to the primary infection, such as gingival stomatitis, pharyngotonsillitis, keratoconjunctivitis. On the block here, you'll see that there are some manifestations that are seen with recurrent infection, so they are more exclusive to the recurrent infection. For example, the cold sores, the very famous cold sores that you see mostly with HSV-1, this is not a manifestation of a primary infection. This is a manifestation of recurrence. Similarly for keratitis. And then there are manifestations that could happen either with a primary or recurrent infection. Some of these include skin infections like hepatic whitlow, eczema herpeticum, genital herpes, as well as encephalitis and meningitis. Usually HSV is spread by contact, and for you to acquire the infection, the virus should either get lodged on a mucosal surface or on broken skin. It cannot cause infection by coming in contact with intact skin. So starting with oropharyngeal disease, this is mostly seen with HSV-1 rather than HSV-2. So primary oropharyngeal infection in adults is usually asymptomatic. However, you might see pharyngitis and tonsillitis. So if you acquire the infection as an adult, uh, you would very likely be asymptomatic. And it is possible that you might have pharyngitis and tonsillitis. This type of infection, again, mostly stressing HSV-1, um, we usually acquire it as children. More than 90% of the population is already seropositive for HSV-1, so we have already encountered this virus early in life. And as kids, the primary symptoms that appear, um, they usually manifest as gingival stomatitis. That means inflammation of the gums and inflammation of the mucosal lining. So you have bleeding of the gums, ulcers, and fever. And I selected a rather um, interesting picture over here, which um, is more severe than usual. So it doesn't have to be this severe. This is gingival stomatitis in a kid who acquired this as a primary disease or primary manifestation. In Arabic, people sometimes refer to this as alua, if you'd like to remember this kind of terminology. After encountering the virus and before you have symptoms, this is what we call the incubation period. This is about 3 to 10 days. And so let's say it's about a week. Usually the disease is self-limiting. There's no need for antiviral therapy. Um, and so you might use some calming or uh, medications that basically cater to the symptoms rather than the virus itself. So the disease is self-limiting, but it lasts about 2 to 3 weeks. So gingival stomatitis was a primary manifestation. So the virus, after primary infection, it will go into latency in nervous tissues. But then later on in life, due to some factor or another, you might have a recurrence. So again, mostly stressing HSV-1, you might have as a recurrence herpes labialis, which is the cold sore or fever blister. Again, to kind of disrupt this myth that it's possible to acquire the virus and then immediately manifest this kind of symptom. This is a manifestation of recurrence. This means that you have had the infection earlier in life. So typically what you see is a cluster of vesicles. These are vesicles that appear at the border of the lips. And then these are painful early on within the first week, and then this gradually heals. It resolves without scarring within about a week or two. And then the frequency of recurrence varies among people. So there's no one size that fits all. It's difficult to guess how and why you might have a recurrence. For different people, it's different reasons. For some people, it's exposure to the sun. For others, it's under stressful conditions. And these are probably the most two common reasons why people have these recurrences. However, this is kind of difficult to completely track down. On the other hand, genital herpes is mostly seen as a manifestation of infection by HSV-2. However, it might be caused by HSV-1. Primary genital herpes, so having the manifestations when you're first infected, this can be rather severe and might last for about 3 weeks. The lesions are quite painful and you usually see fever along with the lesions. It doesn't mean that the lesions are always contained to the genital region. It is possible that the person might scratch that area and then might spread the virus elsewhere, and so you might see extragenital lesions as well as possible meningitis. This meningitis is usually aseptic. If you're not too familiar with this term, this is a term that's used to contrast a bacterial meningitis with something else, such as a viral meningitis. So with bacterial meningitis, usually in the CSF, if you take the CSF and you try to culture it, something will grow on a bacterial culture plate. And so it's referred to as aseptic because you can take the CSF, try to culture it, and then nothing will show up on a bacterial culture plate. So genital herpes can also recur after a period of latency. This is quite common. So recurrence is not infrequent. However, it is much milder than the primary manifestations. So you see fewer vesicles and it will last about 10 days. There are manifestations of infection by HSV-1 and 2 besides uh, the ones we've we've seen in the previous couple of slides. Ocular herpes could occur if you have an infection of the eye. This might be a primary infection, but also could be recurrent later on in life. So you could see keratoconjunctivitis, chorioretinitis, ulcers, vesicles, cataract. And so usually if you have a recurrence in the eye, this indicates that the primary infection happened directly there. So we're not trying to say that you might have basically oral herpes and then recurrence will happen in the eye. No, usually if recurrence happens in the eye, this is usually due to a primary infection that also happened in the eye. Skin manifestations, we don't usually see skin infections in healthy individuals. However, if you have an abrasion or broken skin, you might see a manifestation, and that includes herpetic whitlow, and that's an infection of the finger due to broken skin there. And these are a couple of pictures of what that might look like. This is seen in healthcare workers, and so again, just a reminder, please wear your gloves. In patients with eczema, so they already have skin condition. If you have a herpes infection on top of that, this is referred to as eczema herpeticum. Encephalitis and meningitis, this could be primary, this could be a recurrent infection, and if it goes untreated, then yes, you have a high mortality rate. So of course, meningitis or encephalitis, these are serious conditions. Neonates might be infected with these viruses, and you might see lesions. You might see encephalitis or meningitis plus lesions, or if the neonate is quite young, or if their immune system is not that great, you might see a disseminated disease. And so this is potentially deadly if it's not catered to quite fast. And if the person survives neonatal herpes, they still could end up with some form of disability. So disseminated herpes, it usually occurs in immunocompromised patients. We don't usually see it in somebody with a healthy immune system. And so this results in widespread lesions. This could affect multiple organ systems as well. Now for the next section, Dr. Nisreen will be joining me, and she will be discussing a clinical case pertaining to HSV-1 and HSV-2 infection.
This is a 31-year-old man who presents with painful penile lesions of 2-day duration. He has no sexual partner, but does not use condoms consistently. On physical examination, you find vesicles on the penile shaft. Your patient has a low-grade fever, but no penile discharge. What is the most likely diagnosis? This is most likely infection with HSV, herpes simplex, because of the painful lesions and the absence of discharge. The low-grade fever is also characteristic. How do you confirm the diagnosis? We usually send a swab, and that swab is sent for HSV PCR. What is the next step in the management? We usually prescribe antiviral medications for the patients where the clinical picture is compatible with infection with HSV-1 or 2. We rarely wait for the test results, as they may take time, and we expedite the management by starting treatment immediately. Many times, you will not even have to confirm the diagnosis by a PCR swab. The treatment usually consists of acyclovir or valacyclovir. And how do you advise your patient? Your patient should know to avoid any sexual contact without using condoms. We also discuss the possibility of future recurrence of the lesions now that he is infected with HSV. And we recommend that he discuss this with the sexual partner in this case and recommend treatment of the sexual partner.
The diagnosis of an HSV-1 or an HSV-2 infection is highly reliant on the clinical manifestations, which are more or less specific to these viruses. We don't usually rely on serology because it takes about a couple of weeks before antibodies appear, so you cannot rely on it for diagnosing an acute infection. However, of course, it could be useful after the fact if you'd like to figure out if somebody is immune to these infections by, of course, looking at IgG levels, for example. PCR can also be used. You can also do cytopathology. There are certain microscopic indications of the infection. You can do the Zank smear or the Zank test. So you will see giant cells. These are syncytia. These viruses have a tendency to help cells fuse together. So these are multinucleated gigantic cells. However, this is not a specific test. So it's positive in HSV, it's positive with CMV, it's positive with varicella, as well as an autoimmune skin condition that is called pemphigus vulgaris. So this is not really a specific test. So in most modern labs, this has been replaced by using immunofluorescently labeled antibodies to figure out whether HSV-1 or HSV-2 are causing an infection. You could also cultivate the virus. You could try and isolate it, um, and that will enhance, of course, the specificity of the diagnostic test, whatever that follow-up diagnostic test might be. So you culture the virus, and then you could possibly do PCR on it, or you could culture the virus and then do some antibody-based tests on it. Treatment, acyclovir, valacyclovir, and vidarabine can be used. You learn more about these in the lectures with Dr. Natalie Schaap later on in the course. Vaccination, we don't have a vaccine that can be used for HSV at the moment. And of course, there are ongoing studies that show promise. In the next section, we'll be discussing the varicella zoster virus, which is human herpes virus 3. Like the other human herpes viruses, VZV doesn't seem to have an animal reservoir. Usually, this virus is acquired via the upper respiratory tract mucosa or by lodging of the virus on the conjunctiva. First, what will happen after you acquire the virus during the incubation period, what happens is replication in the cervical lymph nodes. These are the regional lymph nodes. And then what happens is a primary viremia that allows seeding of the liver and the spleen, where most of the next phase of replication happens. During this period, we also have establishment of latency. This happens in the trigeminal and dorsal root ganglia. So again, VZV is an alpha herpes virus, and so it will cause latency in nervous tissues. So this is the first phase. This is the incubation period. It could last a couple of weeks, anywhere between 10 and 21 days. Now, the next phase for that to happen, you need the secondary viremia first. The secondary viremia, so the virus will spread from the liver and the spleen, mostly where we have most of the replication during the incubation period. So what happens next is you have the secondary viremia from these organs, and this will seed the skin and the respiratory mucosa. So at that point, the virus is shed in respiratory secretions and the person is contagious. What we have is vesicular eruption. These are the manifestations. You see a rash that we call the varicella. This rash is also called chickenpox. And you see hundreds of blisters that appear. As with many other viruses, we rely on a specific immunity, so antibody immunity, and then cell-mediated immunity to terminate viral replication. This virus is highly contagious. Usually in children, it's a mild disease, and so you worry more about adults where it is more severe, and of course in the immunocompromised. The manifestations usually last about 5 to 10 days. Now, the person is contagious about a couple of days before the rash appears, and the person remains contagious about 5 days after the symptoms have subsided. An alternative way to assess whether the person is no longer contagious is to examine the vesicles. Once they have dried up, the person is no longer contagious or presumed not to be contagious anymore. Now, the vesicles, they harbor the virus itself. Complications are rare and mortality rate is low in the normal population. Some of the rare complications include encephalitis or pneumonia, disseminated intravascular coagulation, and possibly disseminated varicella zoster virus, which means that the virus has spread to various organ systems. And this might happen in specific risk groups, of course, people with weaker immunity, such as neonates or the immunocompromised. So what we discussed on the previous slide is the varicella, which is the rash that you see, the blisters that appear during the primary disease, or those were primary manifestations. The virus goes into latency in nervous tissues. So later on, it might reactivate, and you'll see manifestations again. In that case, what happens is what we call herpes zoster. This is the most common type of recurrence, herpes zoster or shingles, the most common type of recurrence with VZV, of course. So this happens in about 20% of people who had the primary infection. We don't entirely understand the triggers, but they probably include some kind of decrease or depression in the immune system, like aging, disease, or a therapy that results in immune status decline. However, rather considerable number happens in healthy young adults with no other underlying conditions, so this cannot be ignored. You might see shingles or herpes zoster in somebody uh, who is a healthy young adult. The manifestation, shingles in Arabic, we refer to it as nar. So how does this happen? So remember that the virus has gone into latency in our nervous tissues. It might reactivate in a certain nerve that innervates a certain area or a certain area of the skin or the mucosa supplied by that nerve. So it reactivates in a specific nerve. And then what happens is that replication happens in that nerve. And this is why you feel the intense pain in that area. This is followed by appearance of the vesicles. This happens along the tract of the nerve itself. And so the most commonly affected areas are the trunk, the head, the neck, and the eyes. This rash will heal within a month, so somewhere between 2 and 4 weeks. After the blisters have or the rash has disappeared, some people suffer from post-herpetic neuralgia. So this is nerve pain. This could last months to years after the rash heals. Recurrences are rare, so once you have the belt, if your immune system is rather fine, you do not usually see recurrences. So recurrences are, of course, a reason to worry about the immune system status. And usually you only see one belt or stripe, at most sometimes two, but more than one stripe is usually a reason to think about possible immunosuppression or something wrong with the immune system. Now, these blisters that appear on the skin, these are contagious if you directly contact them, just like the regular varicella rash. These are contagious. However, if you have somebody who gets exposed, who's being exposed for the first time, so this is a newly infected person, the person will develop varicella. The person will not develop shingles because this is a manifestation of recurrence. Now, the person who has this manifestation, so shingles or the herpes zoster, um, before the rash appears, so during replication within the nerve, and after the rash has disappeared. So if you do have post-herpetic neuralgia, these are not usually contagious stages. We do not consider these stages to be uh, contagious because the virus is not out there on the surface of the skin, so it cannot be transmitted to somebody else. At the same time, the virus is not systemic; it is in the pre-rash stage, so the virus is contained within that nerve tract. Maternal varicella in the first 2 trimesters. So if a mom, somebody who's pregnant, acquires the infection within the first 2 trimesters, this might result in the death of the fetus. And possibly there's a risk of congenital varicella, so 1 to 3% risk of the baby surviving and having congenital varicella. This means you have skin lesions, you have eye and limb deformities, and central nervous system defects, of course, resulting in a form of possible mental retardation later on. Infection in the third trimester. So, if the mother acquires the infection and has varicella within in the third trimester, this is associated with herpes zoster in infancy. So, if you see an infant who has shingles, that belt or stripe of rash, this highly indicative of having been exposed or the mom having been exposed during the third trimester. Neonatal varicella could happen. And if a neonate acquires the infection, the disease could range from something rather mild to something rather disseminated or fatal, depending on how fast you treat it, if it's catered to very well, and depending on the immune system of the neonate. Now, for the next section, Dr. Nisreen Rizet will join us again to discuss a clinical case, and she will help us wrap up this session.
A 24-year-old woman presents in the early afternoon to the urgent care clinic with a rash on her scalp and forehead noticed this morning. The rash rapidly spread to her shoulders and back and neck areas. It is pruritic. She has a low-grade fever and reports a sore throat 2 days ago. She works as a pediatric nurse and has no history of previous chickenpox and no vaccination against varicella. She took care of a child with confirmed chickenpox 2 weeks prior to presentation. On physical examination, her temperature is 37.7 Celsius. She has mild pharyngeal erythema. The lesions are vesicular and itchy, and they are at different stages. Some are more erythematous than others. What is the most likely diagnosis? As you suspected, this is most likely chickenpox or varicella. We usually rely on clinical criteria to establish the diagnosis. As far as treatment, we usually do not recommend treatment for young healthy adults and reserve treatment for immunocompromised patients. Treatment with antivirals such as acyclovir and valacyclovir. How about precautions? In a healthcare setting, this nurse was exposed to a child sick with chickenpox. She had no immunity to varicella, having not received the vaccine, and she had no previous infection with chickenpox. Usually, we recommend that healthcare workers who do not have immunity to chickenpox not to take care of individuals with suspected chickenpox or varicella or even zoster. The vaccine is protective and will offer immunity. It is usually recommended in the United States for children and started in childhood. And it is definitely recommended for healthcare workers who have no previous history of chickenpox. VZV is the virus responsible for the disease chickenpox. The diagnosis is typically clinical because the disease is very characteristic, and rarely do we rely on laboratory methods to confirm the diagnosis. You can isolate the virus from the lesions and document that by sending a PCR test from a swab of any of the lesions. Other methods of detection include direct detection, which is done by microscopy and immunofluorescence. Serology is usually not used if we are suspecting chickenpox because we can easily send a PCR test. However, the IgG is needed and is a marker of previous infection and immunity to VZV. Treatment, as we said, is not required in uncomplicated cases. You can use anti-itching creams. Proper hygiene is recommended also to prevent secondary bacterial infections. And usually antiviral therapy is administered to patients with shingles who are more older than 50 years of age, and for example, acyclovir. The vaccine is a live attenuated vaccine to varicella and shingles, and there exists a subunit vaccine to shingles. Both are available.